come on the stage. Dr. Divakant, Dr. Digvijay sir, Dr. Karan. So I request the first speaker today, Dr. Simar has requested to present a little early. So if you can start. He's a vitreoretinal subspecialty person. Please start. From Advanced Eye Institute, PGI, Chandigarh. Long list of awards that he has.
Good afternoon, everybody. Thanks to YOSI and the executive members for giving me this opportunity. So I have been asked to speak on preparing for the worst in theory and practical exams during our MS and MD. So I think I'll just dwell on something which helped me during that phase 5 years ago and see if the same can help you in the future. So I have no financial disclosures. I'll be just taking on 10 points that can help you. First is keep your eyes and ears open. I think that starts from the time you enter your residency. We see patients, that is one thing that we are not short of here in India. We have lots of them. So see patients, you get a lot of opportunity to do that. See them nicely. Keep 1 or 2 interesting patients in every clinic day for the evening. Make them wait, pamper them a little. For your seniors to ask them questions and do a detailed discussion on them. And don't be afraid to ask them how or why this happened. Nobody is testing you during those 3 years. They might be a little harsh sometimes, but ultimately that all thing is for your own good. The second thing is own the patients that you see. Once the patient that you have seen and needs a management, that patient should want to come back to you. So every time if the patient has to come back after 2 days, he should be searching for you. Not that you are seeing another set of patients and that patient goes somewhere else. So you should have that kind of rapport with the patient, explain him his disease so nicely that he searches for you and comes to you. Even after surgery, once you operate your own patients, we have so many of the residents who operate and even post-op day 1 they don't see it. The consultant is directly seeing it. So that is something that is not done. You don't learn that way. You don't prepare yourself for the exam that way. And seeing a disease evolve through the course, just seeing one new patient one day and not seeing how the course went over the next month or the year does not help. So you should see the disease evolve and you won't need to read your textbook after that. Read about your patient. So any new word you hear in a day, one disease, one word, okay, you heard VMT. What is VMT? Just go and even the simple Google search will give you the headline about it. You'll know a new word. Rest basic pathogenesis, everything you'll read, but just all the terminology, especially with the imaging coming in, so many terminologies are coming in. So that is one important thing. If you're going to do a new surgery the next day, it's always good to go on iTube, YouTube, see a few videos how people do it, and then learn from that. Keep one standard textbook for ophthalmology. So I had Yanov. One textbook that you read cover to cover at least 3 to 4 times during your residency, and the same you use during your exams. Multiple textbooks you can use for one topic reference and everything, but one textbook should be read complete so that you don't miss any topic of ophthalmology once you're done with your MS. Once you go into a subspecialty, then that's different. And review articles, major reviews, they are not textbooks. They are written by you and me, not a comprehensive review. So they are not textbooks. You should keep one textbook that tells you the basics. You will need to supplement that with latest articles. Yanov is not going to give you all the latest DRCR protocols and everything. That you'll need to read more, but always keep one textbook. Attend and present. Conferences give you a lot. They keep you abreast with what is going on in the world. You can validate yourself seeing that the other person is also doing what you are doing, and you feel more confident about your work. or you see something new and you know that this is going on in the world, this is where we are progressing. We see gene therapy here, we don't have it yet, but we know that something is going on with Luxturna and something, we have to be ready for that. So attend conferences, present your work. A critical review always gives you something more to learn and increases your confidence. All this ultimately helps you in your exams and making you a good ophthalmologist. Closer to the exam, maybe the last 6 months, plan your study well. Keep a list of the last 10-year questions of your institute, your university. Divide that list specialty-wise. Don't do it year-wise. Specialty-wise, once you're picking up one specialty, do all the topics that have been asked repeatedly. I'd like to put down a number how many times that topic has been asked in the 10 years. Each time I'm writing them down. So that helps to tell you the importance of the topic. And preparing them well will cover you enough to pass you. It will get you more than 80% of your topics that are going to be asked in the theory exam. And again, stick to one standard textbook, not review articles. Second most important thing is teach ophthalmology. If you have a small group or even whole of your batch, once you have read a topic, try and teach it to them. Once you teach it, you will learn it so well, you would never forget it. So once you teach it, you will want to read about it more, you will want to read the pathogenesis better, and then you will learn it better. In the exam, the most important thing, I think that concept is gone where the number of pages decided the number of marks we get. It's getting the message across to the person. Everybody is busy these days. They are just going to shuffle to your exams. So just write point-wise so that they know you know the topic. Make as many bullet answers as you can and flowcharts as you can so that they know you know the process of what you're talking about. In the practicals, it is totally your skill to lead the examiner to what you know. The examiner will always know more than you, but you have to take them somewhere where what you know. So speak only those words which you can clearly describe further. The answer that you give is your next question. And no loose terms like mild vitreous hemorrhage or a severe corneal edema. If there is a classification and you have followed that, very good, but otherwise no loose terms. Just say there is vitreous hemorrhage, no loose terms. And no abbreviations in the exam. Treat your examiner as if he is a layman or a first year medical student and try to teach him. In that way, he'll know the depth of knowledge that you have once you are. Don't consider that he is an expert and you say CSME and that he'll understand. Use the complete full form of the abbreviation. And the last thing I would like to say, it's not the end of the world. Prepare your best and answer whatever you can. If you don't know the answer, just say no. That will help stop the discussion over there and move to another topic which you might know. Else it will keep lingering along that line and your number of marks that you get will go down. Most examiners that come want to pass you. You have to strive very hard to make them not do so. Thank you.
Thank you very much, Dr. Simha. In the interest of time, we would like to start the keynote addresses first. So, India was very well known for the Gurukul system of education, and now it's also making leaps and bounds in the internet-based learning. I invite Dr. Anand Bhandari, sir, to deliver his keynote address for Gurukul to e-school, teaching technique transformation.
Thank you, Chair, and thank you, AIOC, for giving me this opportunity. Regards from and well wishes from Bangalore, from Ramaya Medical College. To introduce, there is a definite rapid growth of Indian medical education system. From 270 colleges in 2008, just in 12 years, we have doubled the medical colleges in India. This will exponentially increase as this budget says that the government plans to change all district hospitals into medical colleges in the state. India has the highest number of medical educators in India, in the world. So let's go into the world scenario. How did it all start of teaching and learning? 5th century students were like apprentices. They used to come sometime, work with a person who knows a little knowledge about medicine, and then go back and do his other works. So it was a part-time job to learn. On the 10th century, there was little significance of pre-academic teaching, which was more common in Italy, where mentorship started. And in the 16th century, with books coming into play, they emphasized more about observation and measured experiments. On the 18th century, we graduated to hospital-based clinical medicine. We see this University of Illinois, where we have a MOU with Ramaya Medical College. We have staff exchange programs with them. And in the 19th century, experimental methods started, and specialization and lab-based teaching also started in the 19th century. But now in the 21st century, we have Advanced Learning Center. This is Advanced Learning Center of Ramaya, which was picked at 2015, where Professor Dua was there with us. So this slide doesn't need any introduction nor the heading. We have the 4 great doyens of teaching in different subspecialties of the world of ophthalmology: Von Graffe, Sir Duke Elder, Charles Creepens, and then Jose Baraker for the corneal. Indian scenario from the world, we get down to India. Ayurvedic medicine, as you know, is a very oldest part of teaching, where practiced in 2000, 3000 before Christ. Guru Shishya Parampara, this is a Brahminical system wherein an individual training of students was done by skilled practitioners. Then we led into allopathic system by the missionaries who came on the 16th century to the soil of India. And the first medical school was started in Calcutta in 1824. 1881, there's some more history. Meritorious students were admitted in Bombay and Madras to become hospital assistants. 1917, our state had a Mysore Medical School, which is called, started to train sub-assistant surgeons. So you see the difference. Still the doctor thing is not come yet. These trainees had to undergo 4 years, and then the first degree licensed medical practitioner was given to them. 1924, the Mysore Medical Schools upgraded to Mysore Medical College. So this is a photograph of Nagpur in 1870, where you see the graduates with the teachers. This, without touching this momentum, this building, nobody can tell a history of ophthalmology. This is Egmore Eye Hospital, Regional Institute, which is the second one in the world to be set up only for exclusive, other than Moofield Eye Hospital, which was the first. This structure was the first in the Indian subcontinent as well as in Asia. And without touching this RP Center, nothing is. This is the largest volume of postgraduate students' education nowadays. It is about average of, it's an average, sometimes it is less, sometimes it's more. Every 6 months there is an intake of 19, and this also is an apex body of all the programs of India. It is distributed to other parts of India like NPCB. Knowledge transfer. Yeah, teaching helps in knowledge transfer, that we all know, essentially for the maintenance and advancement of health care system. Delivery of the factual knowledge about the topic and exposure to tools. Teaching also helps in development thinking processes required to make critical decisions with the information what is in hand. Pedagogy, this is a teaching methodology where practice of teaching, especially as an academic subject or a theoretical concept. Traditionally, medical teaching, as you all know, is a combination of didactic lectures and in the classrooms, and then there's a Socratic method where we take the students to the clinical settings and teach them. Merits of didactic lecture, as you all know, is a traditional delivery of a factual knowledge. Very large group, nowadays 350 students are in a classroom. A large topic can be covered very short time, there is no interaction, so the teacher keeps rattling out what all he knows in that subject. Demerits of didactic, a more passive way, there is no check of the listener whether he has understood the topic. Lectures do not correlate with shortest attention span, subject to a speaker. So a good orator as a teacher would deliver a very, very good lecture than a person who is not having some oratory skills. Self-learning is a must in all teaching learning, because self-learning is the one which emphasizes on what you know and how to write your exams. Challenges: the rapid growth of medical education in India. 3 major issues is happening. Standardization, quality of medical education across the India has not happened so far. The newer medical system, the newer thing which started this year has this standardization. Implementation of effective solutions to address an artificial, there is a definite, as you know, like practitioners, the teaching doctor also is unequally distributed from tier 1 to tier 2 and tier 3 cities. Formal teaching of teachers in medical school has not happened so far. Even to start with first or first grade or second grade of schooling, people have M.Ed and B.Ed degree, but there is no special training for any medical teacher or a degree before they start that training. Medical college, as you know, undergraduate is about 1 year of ophthalmology, postgraduate 3 years, now DOs are not there, and fellowship is in subspecialty starts from short 2 months to 2 years. Advancement in this is that the Advanced Learning Center, we have one good one in Ramaya. Hands-on workshops can be there, and cadaveric lab is also present. There's definitely faculty exchange program between the universities, and PhD in different universities are also got in subspecialties. Definitely going ahead, where e-learning is the key use of internet technology to enhance knowledge as well as performance. E-learning is centered according to the learner, not according to the teacher. So learning sequence he can adjust, and pace of learning and time and media content also is adjusted by the learner himself. And effect as a traditional instructor method, as effective as it as a lecture. Provision and for having a whole library in a single device, so you can see the even the huge books and the spinal cord is relieved of all this heavy carrying. Combination traditional teaching with e-learning is a must. Socratic method with in the scenario for the hospital, and online learning helps in enhanced student motivation and self-confidence. There are definitely, you know better than me, online websites are there, and Facebook, Instagram, Twitter for eminent ophthalmologists, for nothing else other than that. Self-learning using the search engines as well as webinars. Now we have a lot of webinars coming in, and live surgeries also beamed across the country and the world. E-learning merits instant access to knowledge anytime, anywhere. Diverse literature is there, and online journals, courses and tutorials all available in a single click. Definitely there is demerits, a lot of authors, lot of lecture, and you have to choose among the best. Comes with a lot of distractions, and provision of effective e-learning is not cheap at all. So the facilitators for these learning and teach is gurus in the first place, and mentors, and then we have teachers and consultants in the hospital setup, and senior counterparts are the most important facilitators, as we all learn from our senior postgraduates. And definitely now going on to the online sector, we have cataract coaches and online gurus. So in conclusion, medical teaching is constantly evolving. Pace of medical college growth should match with the pace, with the adequate availability of a mentor, or a lot of mentors are necessary. Focus on all areas of learning, like self-learning, didactic lectures, as well as mentorship, and application of e-learning is a must in all the above areas. And as William Ward said, a mediocre teacher just tells, a good teacher explains, a superior teacher demonstrates, but the greatest of the teacher inspires. Be a learner, be a teacher.
Thank you very much, sir. Any comments? So we would now like to invite Dr. Steven Mansberger from Portland, Oregon. He is the chair of ophthalmology and a glaucoma subspecialist, also known for his work on scientific papers. And he would be presenting on the topic how to read scientific paper and interpret statistics.
So I just want to ask first, if you had to choose between hearing how to get a paper published versus what statistical errors are most common, what would you choose? Did you want the first about how to get your paper published, or would you rather have the second one about, statistical errors that are most common? First one. Okay, we got some of both. First, second. All right, so I'm doing the Socratic Method as he talked about here. So what I'll do is I'll go through a little bit of both of them, and I'll just go through some highlights, I think, of each of these issues. This is just a picture near my home in Portland in the Northwest, and these are the Olympic Mountains. And this is a beach near my house called Cannon Beach, and you have these, that's called Haystack Rock, that monolith coming out in the distance. So I would love if you come visit me sometime. So what I want to do is give a simple framework for publishing papers, and avoid common mistakes with statistics. Now, this book is a book that I recommend. I have no financial interest in it. It's called Successful Scientific Writing. I didn't discover this book until about 5 years after I finished my residency, and I already had struggled through trying to write papers. And this book had really kind of revolutionized how to do this, and it makes it so much easier for me to write my papers and get them published. So why am I giving this talk? I'm on the American Journal of Ophthalmology's editorial board. I'm an executive editor of epidemiology, and I'm also on the editorial board for Journal of Glaucoma, and I do reviews for a number of different journals. And I've reviewed over 1,000 articles. And I'll tell you, with AJO, I right now have 5 to review. I got 5 today. And what I'll do in these papers, I'll look at these papers very fast, and I'll decide whether it even gets out of my list to one of the other reviewers. And the number one cause of rejection, it's unclear how researchers or clinicians would use this information. So you write a paper about pediatric glaucoma and the rates of blindness, and you don't say how I'm going to use it. I don't really know that much about pediatric glaucoma, but you don't tell me about why this is important. So that's number one. I'm just going to reject it. If you can't even tell me why it's important, I don't want to have to spend any more time on it. Number two, it's unclear how the study adds to the current literature. So sometimes when you're a resident and you're working under somebody, you think it'd be a really good idea to do a paper about something. And you spend all this work doing this paper, and then you realize that there's already been 10 papers written about this. So you've spent all this time working on this project, and you realize you're the 11th of 10 other papers. So you've got to say how it adds. Is there something different? Has there never been a study like this done in India? Is the proportions really different? What is really different about this paper? And number 3 cause is it does not follow a hypothesis testing framework. So it might be just something you're interested in, but you don't have an hypothesis, such as, does air pollution lead to more dry eyes? You just talk about how much dry eyes are in your community, but you don't have a hypothesis testing framework. So that's number 3. And so I'm going to give a couple things from this book, which I think is very useful to write. It's really fast to write your papers. You have a 3-paragraph introduction. First one is why it's important and why should the reviewer care. So in the first paragraph, you can't tell me why this is interesting. I'm going to reject the paper. Second paragraph, what's the previous research? And really succinct. Just make sure you've done some sort of literature review on this. And the third paragraph in that first sentence is what I've already talked about, why this study adds to the literature. And your last sentence is how researchers or clinicians could use this results. Without those 2 things, I just go through the introduction and it's rejected if you don't put those in there. The methods, first paragraph, it's very, very important to talk about your study subjects and your IRB approval. If you don't put that in the first paragraph and I've got to look for it, I'm going to reject it. That's the first thing that I got to look. If it's not IRB approved or even sent to the IRB and they said it doesn't need to go through any type of further review, you have to have that done. The middle paragraphs of the methods should tell a story, and the story should be so detailed that somebody else, when reading it, could replicate your experiment. If they can't replicate your experiment, then it's going to get rejected. And the last paragraph is statistical analysis. The results are pretty straightforward. The first paragraph is going to talk about your study subjects and the IRB approval, and the middle paragraph is the most important findings first, or the findings in the same orders of the methods. And then the discussion, it's pretty straightforward again. I always do the same formula. Explain again, why did you do this study? We did a study on congenital glaucoma because we have the highest rates of congenital glaucoma and no one understands why. Give your major findings. Next, congenital glaucoma was associated with family history or with genetic defects or with pollution or whatever it is. And the last sentence is how clinicians and researchers could use these results. So, working on a public health measure to treat air pollution would improve vision and prevent congenital vision loss. So you kind of tell the story, and all of a sudden, I'm like, wow, this is a good paper. It's going to get accepted. I'm going to send it out to the other reviewers. The middle paragraphs explain the most important findings in context with the literature, and then stick to your study findings. And then the last paragraph, whatever limitations you might have. My other advice is there's something called passive voice when you're writing, and there's something called active voice. Active voice means there's a subject, a verb, and an object. It's how we talk to each other. Like, hey, Sam threw a ball and hit his sister. That's active voice. Saying his sister got hit by a ball. That's passive voice. You don't know who threw the ball at. So you want to write an active voice that's much shorter, much more clear, and much more descriptive. So I'm not going to go too much over statistical errors. I'm just going to show you this one example of where I see a big error and I just reject the paper. This intention to treat analysis. And what you want to do with this one is you want to randomize them to a group of what kind of treatment, and you want to present the results of all those people that went through this treatment. So, I'm a glaucoma specialist, so if I'm doing a new glaucoma surgery and this glaucoma surgery is new, I want to present the results in everybody who did the glaucoma surgery. So here's an example of this attention to treat analysis. We have treatment 1, treatment 2, and you'll see here you have some people that didn't finish the treatment. You're still going to report on them with an attention to treat analysis. There's a different kind of analysis called per protocol. It's a very biased analysis. And what you do is only report those that were compliant with your treatment. So if there's a huge number of people that weren't compliant with your treatment, maybe your treatment isn't a good treatment to begin with. So you always want to give your intention to treat analysis. So here's a good example of where they didn't. This is a well-published paper about a new glaucoma surgery. And they implanted one of the Zen stents. And what you can see here, they had the planted population. And what did they do? They discontinued patients because of a stent explant. So they didn't include those in the study. And this is the results of their study. And what you can see, they call it an intention to treat population because they want to get it published. But what they did is they excluded those that had a secondary complication. So again, this is a big error, and I'll reject these papers as soon as I see that. And I'm not going to go too much about this, but there's other common errors that you'll see. You need to control for both eyes if you use the study. You need to, if you have a statistician that's working with you, you need to make sure they understand how calculated values are created. And this is my last slide. Just when you're writing a paper, the first thing to do is to do a good literature review. They say one literature review, 1 hour of literature review will save you 1 month in the lab. So just do a literature review. Engage a biostatistician with your study. And I think doing a little bit of your own analysis can teach you some about statistics, and then the results should make clinical sense. So anyway, this is our group out in Portland, Oregon, and I thank you for allowing me to speak today.
Thank you, Dr. Feynman. That was a very enlightening talk, I think, for all of us. Mm-hmm. So there's a query here. So a lot of times when we are sending papers from India or from other countries, we're not essentially all that comfortable with the syntax of the English or the grammar language. So how do you look at errors of those sort in the paper? Is it something that you would generally spare, or is that something again which amounts for rejection? Yeah, so I think it's a good idea. I mean, even me, when I write papers, I like to have my wife write it or read it. She's not an ophthalmologist, she's just a teacher, but I like her to read my paper to make sure it makes sense. And so I think it's good to give it to somebody who's a native English speaker just to read it and do some of those edits. But let's say that you've done your best and you've sent it to me, and you've done all those things I said. It's important. It's a new finding. You've done the statistical analysis correctly. You've reported everything correctly. It's gone through the IRB, but it has a lot of grammatical errors. We still send it through, and we have the other reviewers do that, and then we have a copy editor who will help fix all those grammatical errors. So, but the more work you put on the reviewer, the more likelihood it's going to get rejected. So you just want to try to get those fixed before you can send it in. Right. So are there any questions from the audience? Somebody?
Just one more question to you.
Sure.
This is from a personal experience. Now, there was a particular rare case in glaucoma, which I wrote a paper on. There were another 3 papers on the similar topic. Extremely rare case, I don't want to go into the details. They were reported in the Western literature, but never in India. But the paper was rejected, saying that already such data exists. So in these situations, do you think that reporting it in the in the Indian subpopulation, papers should not have been rejected? I mean, are there any criteria regarding to that?
Well, I think it goes back to that first thing. If you you have to think about this. You know, how would this add to the current literature? And if the answer is, oh, we just reported the first time here in India, then you're right. It might not be accepted, but maybe in an Indian journal it would get accepted. Or if there's something very unusual about your case, make sure you highlight that, and then that might pique the editor. You know, one case report is really hard to publish in a lot of places too. So it might be good for like a video journal or a teaching case, something like that. And then you can call it published.
Thank you.
Thank you.
We would invite the next keynote address speaker, Dr. Thiagarajan Jay Bhaskar. Is he here? Since he is not here, I request the teach to reach expert Dr. Pranesh Balasubramaniam from Aravind Coimbatore to please present on does no research really mean oblivion? Options for the young ophthalmologist who's unable to publish.
So in the meantime, he's setting up the his system. I'll just say what Simar Ranjan actually had mentioned. If you have a grading for a particular disease, use the grading. Now, how it can backfire? If you say severe corneal edema, it can backfire sometimes. I had a patient who had gotten operated by some other surgeon. 20th day post-op, he had subconjunctival hemorrhage, which was very diffuse. I just happened to write severe subconjunctival hemorrhage. Now, subconjunctival hemorrhage is subconjunctival hemorrhage. You cannot gradify it as severe or mild or this thing. I didn't know that the patient was trying to get a second opinion so that he can sue the first doctor. He took the paper, took it to the first doctor, threw it at his face and said, see, another surgeon has seen it and he has written severe subconjunctival hemorrhage. You owe me 10 lakhs. He started blackmailing. The other guy turned out to be a batchmate of mine, which was very unfortunate. This guy called me up and he said, yeah, tune severe kyun likha? Why did you write severe? I said, I'm extremely sorry. I did not pay attention. But since that time, I mean, once you get into private practice or once you enter into a professional field, you cannot have such adjectives added to the clinical words. So pay attention. I mean, it is not just for the students per se. You, as a consultant, have to follow these norms very strictly. That's all. Thank you.
Like a lot of people write the foveal reflex. I think retina people, it's either present or is it absent? Is dull actually a word in that or not? But can you write it like that? Because anyway, it's either present or it's absent, right?
It's a qualitative way of mentioning that. But idea is to use what is, what are the scientific terminologies that are there rather than English adjectives and things like that to findings. Yeah, sorry, we'll proceed.
Dry fovea is also another term they use. Dry fovea. So when you're not sure about what is there in macula, we use the word RP changes. Dry fovea, dull fovea. So hope the crowd is not dull now. So we'll take it from here. So I think I have 15 in this crowd, including the panelists. So it's a very small crowd. So I think can engage more. How many residents are here? Okay, 1 resident. Young ophthalmologists who are not residents. We have 4 here, and okay, the rest are there. Madam, non-ophthalmologist. Still good. No, this is better actually. Yeah. Okay, that's great. That's great. So I think I have the longest talk here, or the longest title, not the talk. It's called No Research Means Oblivion? ? Options for young ophthalmologists who cannot publish. The first thing when I received this talk, I was wondering what is oblivion meant. Seriously, I didn't know what oblivion meant. That was a very different word. How many of you knew what oblivion means? Okay, great. So I have few people who was like me. So oblivion means extinction, right? Will you go extinct? It's like publish or perish. Now, how many of you have publications? 4, 2. Okay, still there are people who don't publish. Good. I'm like you guys. So I'm going to give you some options. What if you can't publish? Now imagine a mountain with success etched upon its peak. There are multiple roads to attain it, right? You have surgical expertise, you have publications, you have innovations. We have one of the speakers, Nilesh, he's going to talk about innovations. Like they have all made a mark for themselves by innovating something new. Entrepreneurs, leaderships. So there are many ways to attain success. I'm saying success means making a mark or making a positive change, not just earning. But I chose a very different path, a path which not many really go into or venture into. That's called teaching. So for next few minutes, I want to delve into this called Teach to Reach. It has been my campaign till now. And I will try to make a convincing talk, I hope so, that by teaching the world, you can reach success. So before we begin any discussions, there are 3 questions which you have to ask. Why, how, and what? See, most of the teachers know what they are teaching. That's very obvious. But how many of those instructors really know how to teach? The technique behind teaching. But even more rarer are those teachers who really understand the purpose of why are we teaching in the first place. So why or the purpose? I'm going to give the young ophthalmologists out there 3 reasons why you should teach to reach success. First is carving a niche for yourself. So resident out there, yeah. So what do you mean by carving a niche? What do you think making a mark means? Is it important to you? Maybe, right. I think most of us who are here, if you're attending here, which means that you have a burning desire to success. You have to succeed, right? You want to really go out there, make a mark. I might be like motivating you, but I'm just saying. We all want that because it's a very competitive world. But teaching really, yes, you can carve a niche for yourself. Let me give you my story in that way. My primary interest is teaching. I didn't really like Ophthal. I chose Ophthal just because I was forced into it. Not forced into it. I had only one option left there. So I had psychiatry, I had Ophthal. I had to choose Ophthal, obviously. Hope I didn't choose psychiatry, basically. But my interest was to speak. That's my primary passion. So I had to put a plus into a minus. I had to integrate my passion into my profession. So I started to teach Ophthal. So this is my YouTube channel. I started when I was like you, when I was a resident. I just finished residency 3 months back, so I'm not very old. Okay, and I started to upload video lectures basically for the pre-PG or the PG aspirants, and slowly shifted the focus towards the PGs. This is what the page is called. It's called the King's Crux. It's a weird name. I don't know why I kept it, but it's there, and it's doing okay. I'm not reached a great height like some of the legends there, but it's going good. So whenever I upload these videos, I put it on my Facebook page as well. And one good thing about Facebook is that you can add your own notes to it, written content. So I started to put these illustrated notes for the residents to understand things easily. And one thing led on to the other. I started to compile topics, and I self-published a book on clinical embryology of the eye. You can find the link on that Facebook page called King's Crux. So basically what I mean to say is, I try to use or optimize social media to my advantage to create a name for myself, or at least on social media. So now this is like my mini resume. This is like my CV. If someone asks me, what are you? I'll say, this is what I'm doing. It's the USP. So publishing on social media is the key term I want to put it here. How many of you access PubMed every day? Oh, great. How many of you access YouTube every day? Yeah? So you don't access YouTube? Ah, great. Everything. So I think the majority goes to YouTube, right? So YouTube has a more reach, more connectability when compared to PubMed. Even now people are watching YouTube here. So that makes a sense, there is an answer for that. Now carving a niche or making a mark might sound very philosophical, but let me give you a very practical reason why you should teach to reach success, you become a better learner. As Sir just mentioned, teaching is not just about giving something to others. You become a better learner. You become the master of that concept more than anyone else. I learned most of my ophthalmology by teaching others. Whatever I taught others, I remember till date. We learn more by teaching others. And this is what this guy told. Who is this person? Dr. Richard Feynman. I hope Sir knows. Sir, you know? No? Okay. He's a very interesting person. He's a theoretical physicist. He's a Nobel laureate, Dr. Richard Feynman. He's an eccentric guy. What he will do is he will ask his fellows, the physics, all those brainy guys, to go and teach complex physics concepts to kindergarten students. Go and teach those kids. So what they will do, they will wrap their brains. They will, how am I going to teach those kids? But in that process, interestingly, they learn better. That is, by teaching a toddler, you learn concepts better. It's called the Feynman's technique. Right? How do I employ Feynman's technique? I teach these people. Who are they? They are my nursing students. They are the best persons to teach. I can't go and teach toddler, but if I teach them, they are getting benefited. I'm getting benefited. And I have to simplify a very complex concept to them. When I do that, I automatically enhance my communication skills to my patients also. It's a win-win. The last reason may not be the most exciting one, but I think the most important one is we create a better future. See, even after my time, the videos I've created, they will stay there published. It's an everlasting legacy I'm leaving on this world by publishing the content on social media. The same goes with publications on your PubMed also. But I feel by teaching the world on social media will leave an everlasting impact for generations to follow. So if not everyone, if each of us teach one, if not many, then we can create a better world to live. The world needs more teachers to put positivity in place. So I've given you 3 reasons why. The 3 types of young ophthalmologists or doctors. The ambitious ones, you can make a mark on this world. The academic ones like me, yes, you can master the concepts more than anyone else. And lastly, the rarer species but the more important ones, the altruistic or service-minded, you can make a mark. You can create a change. So I end it here because we all have a very short attention span and we are running late of time. If you want to pursue this idea further, if you think this is an interesting idea, you can go to YouTube, you can type in teach to reach success. You can see this, I think it's a 14-minute video. You will have more ideas on the other 2 questions, how to teach and what to teach. So how many of you are convinced that you can teach to reach success? Not many seem to be convinced. Okay, fine, good. The crux is this. Publish your passion on social media. We have many examples. We have Dr. Pradeep Mohanta who has published surgeries online. Be the author and the reviewer of your own content. If someone rejects you, relaunch yourself. So no offense. Relaunch yourself. Reach the stars. And now the world is at your feet, ladies and gentlemen. Let us all teach to reach. Thank you.
Thank you so much, Dr. Pranesh. Now, I would like to invite Dr. Aarti Subhash Heda, who's done her fellowship in cataract and refractive surgery from Narayana Netralaya. She's also done ICO fellowship in glaucoma and is the first surgeon in Ghana to use trifocal IOLs. Let's hear about her journey and what she has to say about making an impression in fellowship interviews. Any questions for Dr. Pranesh till the time that she's setting up?
I was curious about with the social media. If you don't continually put stuff on social media, it's harder to find you. So, is there a little bit of a pressure to continue to put something on there, maybe monthly or weekly or something like that?
Yeah, it's more than about the quantity per se. Of course, yes, publishing on a regular timings is important, but more importantly is the quality. I think the content what I published 3 years back are more popular than what I'm doing now. So that still shows that it doesn't have to be, you have to be on time. Maybe for the professional YouTubers who earn a lot, for them it's fine. They have to keep on putting the content. But for people like us who really want to like educate the world, then I think a single video with a quality content should suffice.
So good afternoon. It's truly an honor for me to be a part of this session of AIOS. The topic which has been given to me might be of interest for most of you. As fellowship interviews for ophthalmology kick into high gear this season, I will try to throw light on some important aspects of it. So of the important decisions we have to make in life, career development calls for critical thinking. To me, the word fellowship means a friendly association, especially with people who share one's interest. When you think about fellowship, you might have many questions in your mind. So should I do a fellowship? After 5.5 years of MBBS and 3 to 4 years of residency, the last thing on your mind might be more training. Ask yourself few questions. Are you passionate about a narrower focus? Will additional training help you reach your goals? Do you know enough about the specialty? Does the lifestyle suits you? Does it make sense financially? So fellowships are actually an opportunity to do something exceptional. Fellowship is all about practical experience in the form of surgical and clinical work, which will help you develop the skills and experience required to work in your real practice. Sharpen your professional skills. You'll learn public speaking, community organization, leadership skills, hands-on experience, research. For people, those who are interested in research, fellowships open many doors for them. Personal confidence, you get a career boost, and you develop good leadership skills. So the next which fellowship to choose? Your training during residency plays an important role in making this decision of long-term or a short-term fellowship. Someone who is applying for short-term fellowship in a reputed institute has more chance of getting selected than a long-term fellowship. But competitive fellowship makes your resume stand out. So what do you need to answer yourself is, how were you trained during your residency? What do you want to do at the end of your fellowship and beyond that? Do you plan on a career in private practice or academics? Do the program you are looking at have the opportunities to get you there? What if the circumstances changes? For example, your ideal mentor moves to a new institution. The more specific and honest you can be, the better informed your decisions will be. So which subspecialty to consider? You have an option of doing fellowship in all possible subspecialties in ophthalmology, right from cataract, cornea, refractive surgery, retina, and so on. Choosing a subspecialty perhaps is the most important choice of your young ophthalmology career. It is what you will be doing, most likely you will be doing on daily basis for next 30 to 40 years from now. So answer yourself, is it something that will interest you and keep you stimulated for next 30 years? Prioritize your clinical and research interest. Find your passion. Am I ready to give up the other component of this specialty to narrow my concentration? If so, stick to it and be focused. Talk to a mentor. And consider your desired lifestyle. But don't apply for 2 subspecialty in the same institute. You will reduce your chances of getting selected. So when do you start the fellowship? Go when is best for you. Be aware that the longer you are away from training, the less desirable candidate you may become. So soon after your residency is the best time to go for the fellowship. But believe me, it is never too late. So we are lucky to be born in the era of social media, so we can connect to people of our interest through WhatsApp, Telegram, and Facebook. So study the website of various training institutes and read the testimony of past fellows. Find out who the notable fellowship alumni are and what are they doing now. You should come up with a reasonable list, but unless you have a strong aversion, always apply in your home institute as well. Your chances as your own program are likely better than elsewhere, especially if you have been a star in your residency program. So fellowship actually introduces you personally to a new organization seeking talent. Reach out to a faculty, alumni and advisors. Getting the personal account of their experiences will give you insight that you will not be able to find in any brochure. It may be the case that the top institutes you are not necessarily appropriate, may not be necessarily appropriate for you and your work. A lesser known institute might be the home for groundbreaking research which you are interested in. Remember, the place is going to be your second home. So how do you prepare for an interview? Reread your application, practice answering questions, prepare your own list of questions, and be yourself. So yesterday we had a long discussion and what is expected during an interview. Just to highlight few things, sit upright, make eye contact with an interviewer, and be prepared and enthusiastic. You might feel a bit nervous on the day of your interview, don't worry. Your panel appreciates that it is a significant occasion and you're likely to be nervous. Feeling prepared will help you feel confident. Practice the beginning of your interview well. This will help you to get off to a good start. Justify your choice of institution and subspecialty. So this is a very important slide for me. It pays to note your outside interest aside from medicine. Interviewers are always interested in learning whether you are considering a normal, well-rounded individual. Things like hobbies, sports, music, and other interests and special life experiences often show them whether this would be a right person to have on their team. The purpose of the essay is to tell a bit about you. Think like a TV ad that you have very little time to catch the audience. Keep it personal, interesting, and short. Talk about your accomplishment that exhibits you, how you will be perfect fit for that fellowship. Try and show some genuine passion when you are talking about your accomplishment. Don't fall in the trap that thinking that your accomplishment is too small. The fact is, relating a small accomplishment that is in line with which the company values can be more powerful than an unrelated accomplishment. Certainly put your best foot always forward, but always be yourself and be truthful. After many years of the game, most interviewers have a sense of the good ones out there. So I feel motivated to share my story. So when I was applying for a fellowship in one of the reputed institute in 2014, I had nothing in my resume to impress the interviewer. It was too dry to impress anyone. The only thing which the interviewer picked from my resume was something which I have written at the end in very small fonts, that I'm a national level chess player. And my whole interview revolved around chess. Like I was asked the question how I got interested in chess. Do I still continue to play? Do I want to do anything in future in chess? So I was very surprised to know that I got selected in the fellowship just because of my chess credential. So nothing, no accomplishment is small. Let the interviewer decide that. And to end my presentation, I'll say, if I can do, anyone can do it. Thank you.
Very well presented, Dr. Aarti. So now we would like to hear from Dr. Nilesh Kumar, who is a second-year resident of DNB at Lotus Eye Institute, Coimbatore. He's completed his DOMS, and he's also a very innovative person with bringing up a DIGS Pro device. Let's hear it from him on the topic, how will practice change in the coming decades?
Thank you, Executive Committee of YOSI and AIOS for providing me this opportunity. So I'm Dr. Nilesh Kumar, and I'm going to present my talk on how will the practice change in coming decades. So these are my financial disclosures. So there are 4 main domains that are going to change. That is the diseases that are going to change, the treatment, the diagnostics, and the patient that are having those diseases, that is going to change. But most of the change will happen only when we will change. So how are we going to change? We all are young ophthalmologists. We are going to be the future leaders. We are going to be the future consultants. So we have to stop thinking like the residents right now and start forming our own diagnostic algorithm, our own treatment protocols. Because in most of the medical colleges, still the old protocols are being followed. Long we have moved ahead from drcr.net, everything is individualized, but still it is being taught as that. So if we learn that, after 10 years, when we start applying it, it is already outdated. So we have to change that thinking. That seems to be the voice of you. The award-winning essay by Dr. Pranesh says that we have to have a strong residency, and that is not going to change now. If we want to change, it won't change now. So when we are the leaders, we have to think like that. We have to start training our juniors like that. That will have a greater impact than anything else. And there is one existential crisis that we all think of when it comes for artificial intelligence, that is it going to make us obsolete? But we already are surrounded by it. The OCT perimetry, OCT printout, the perimetry printout, even the Facebook's friend suggestion, everything is artificial intelligence. It is only going to aid diagnostics. It is only going to make our life easier as to which patient we need to focus upon, which not. After that, the role is going to end, because artificial intelligence is never going to imitate two basic human tendencies, that is gut feeling and empathy. They might sympathize because they can be taught that if the patient is coming with diabetes, we can tell you have to say these words. The robot can say that, but they can never empathize. And those two feelings, the gut feeling and the empathy, that forms the patient of the basis of the patient-doctor relationship. So we are not going to be obsolete. AI might make us a little lazy, that's it, not more than that. And how the patients are going to change. So the top 10% who don't mind the money and 20% who think that they need the treatment value for money, those two are being focused upon right now. But there is a bottom of pyramid, 70% patients who are not entering the hospital at all. The next wave, the next 2 decades are going to be focused on that, how to bring the needy from that. We can't bring everyone from that and get into the hospital. But from that, who is needy, that we have to do. So like smartphone assisted glaucoma screening, ROP screening, diabetic screening, here AI will play a role. They will do the screening for us, they will send the patient to us, and then we will be treating. So that is going to change. Apart from that, non-communicable diseases are going to change, become more frequent, because all the children now are having laptops for their homework, tablets for their homework. So dry eyes, refractive errors, glaucoma, everything is going to increase. Apart from that, AMD, cataract, they are going to stay. Apart from that, what we thought, like the carcinoma and all, which were in the upper strata diseases, they are now percolating down into the bottom of pyramid. So we need to have diagnostics as well as treatment ready for the patient who can't afford them. These treatments are not affordable right now with bottom of pyramid, but we have to have that, and that is going to change next. So diagnostic depends on which strata you are going to treat. If you are going to treat the top 30%, you can't skip. You have to have that state-of-art sophisticated treatment, diagnostics. But frugal and innovative is the way to go. These are the patented devices among the many from India. The MI RedCam, that is my Dix Pro, that is the patented smartphone device, and from LVPI Innovative Lab, the perimetry for infants. So why do you think India will be, I think that India will be the leader in frugal innovation is because there is a population that needs it, and the high cost of existing instruments. And apart from that, there is now a translational gap from the bedside to the clinics that is being bridged right now. Apart from that, the treatment domains are going to change. Right now, we have all these 4 domains, the preventive, the curative, the cosmetic, the maintenance. We are now going to be more preventive and more maintenance. And if you are going to be curative, it will have to have the cosmetic factor in it also. So how, the medical prevention of presbyopia, that is the most exciting development that is going to happen. It has entered phase 3 right now. So that is one of the most exciting things that we are going to prevent presbyopia, that is going to reduce the healthcare burden a lot. Apart from that, supplements are already being proven. Yoga, pranayam, cardio exercises that have not been studied, but they have been proven in diabetes and hypertension that they help. glaucoma and ARMD, they have the similar pathogenesis. So that has to be explored in next few decades, and I think that will be one more preventive factor that is going to come. Apart from that, coming to my area of interest, medical retina, biologics have played a major role in last 2 decades. They are going to continue playing a major role with brolucizumab already in approval, abicipar pegol already filed for FDA approval, faricimab and ranibizumab port delivery system already in advanced clinical trials. Apart from that, we are going to have biosimilars, and Opthal remains the only place where LHON has approved gene therapy. RP and AMD, they are already on their way. They are in phase 2, phase 3 trials right now. So Opthal is going to be the hub of the biologics and gene therapy. But why India is going to be leader in ophthalmic biosimilars? Ophthalmic biosimilars are facing the similar resistance that low-cost IOL from Arvind faced. When they came out, nobody was going to believe in their quality. But now you can see it has brought down the cost drastically. Same is going to be in ophthalmic biosimilars. India again has a population. When you see the regulatory guidelines, it is immensely robust. It is immensely robust, except for Russia. Everywhere else the guidelines are robust. Nobody can just get the approval like that. And when we have compared the efficacy and safety also, it has been proven that it is equally efficacious. And there is the only thing we need to fight is the nocebo effect. That is the negative placebo effect. The patient and the doctor both don't believe in the drug. Drug is not going to act. And then the last thing is how the hospital is going to change. The trend does, specifically the trend is towards group practice, but when you think of the patient still believe in solo practice. They feel that there is more connect to the doctors in solo practice than in, this is not only in India, it is also in USA. They have done a survey and proven that solo practitioner is more believed in. So wherever you go, the patient connect needs to be there. That is the main impact. And I will leave with this last slide. Publish or perish, that is a big question that comes every time. But I want to share a little story about my father, who started his residency. He came out with ICC in his kit. He could not afford fellowship at that time, so he didn't do. Once he could afford, he was denied because his age limit was there. So he learned ECC by himself. SICS, now he's doing around 3,000 FACO annually. Just by learning, he came, participated in each and every CME, workshop, conference he could, learned, went back, applied, and came back, learned more. So you might not publish and you won't perish, but if you are going to participate, you are definitely going to perish. Thank you.
Thank you, Dr. Nilesh, for your insightful talk. Next, I would like to invite Dr. Digvijay Singh, our fearless leader, president of YOSI, to present a talk on charting the years after residency.
So I think a lot of this is already discussed now as to in terms of what fellowships are and opportunities are previously. So I'm just going to recap some of that and talk about the years after residency. So, but before that, we need to know about the residency itself. So residency is the best time to learn, all right? This is the time when you want to become like a jack of all trades. You want to learn everything. Don't try and limit yourself in residency that I only want to learn anterior segment, or I only want to do posterior segment, or something of that sort. So it's the best time to read. So that's the time you must read some more. Whether it's your textbooks, whether it's papers that you're reading, whether it's reading from the notes of your seniors, ask questions. Do a research project. So this is also the best time to learn research, because there'll be a lot of people who will be willing to mentor you and who will be willing to teach you. So you must do a research project, even individual, apart from the thesis that you're doing. It will really add to your overall development at that point in time. And try and publish something, attend a conference. So these two are also important things, as Nilesh also suggested, that if you attend a conference, you will learn a lot of things which are happening, beyond just what your textbooks are telling you, and you also get into the habit of doing that in the future. And yes, if you can publish a paper, and I think that's really the best thing that you can do, you should take out that time and do that. But then your residency is over now. So what's the next step? Should you be doing a fellowship? Should you be doing, a job? Should you be starting practice? So that's where we get stuck on these crossroads. So some of the points towards the fellowship would be that if you're going to be practicing in a big city, in a metro city, now people are looking for specialists. The patients are more aware. So probably that's where a fellowship would definitely come in handy. If you're going to work in an institution, if you're going to work into what would be a group practice or an academic institution, again, a fellowship would help you, because you'll get into the speciality of one, you'll get into one speciality, and that will be very, very useful. If you want to become a master for one, so if you got a passion in something in your residency, you said, no, retina works well for me. For me, neuro-ophthalmology was one thing that I was getting passionate about. I said, this is a branch, there's a lot to it. So I decided I wanted to do something in that field. And so if you have a passion, you must, of course, go ahead. And if you want to develop, your own practice further, so let's say there is, you're already working, or you're a second generation ophthalmologist or anything of that sort, and you want to take it further, then a fellowship is what will add to that. So what about a job? When would we be thinking in terms of doing a job, or what would be the right time to do that? So there are two ways that you can look at it. It could either be in the form of a medical college, essentially, or an academic institution, which could be not, even private or public, both. So that's the first point that we need to look at. So this is a place where you can look at a long-term career. So think of this situation, if you're thinking long-term, to be there. Right? There could be, of course, an advantage in short and medium-term training or a job there as well. But essentially, from a medical college point of view, specifically, long-term is what you're looking at. There is the stability, and if you have an academic and research interest, this is what you should be looking at doing. The corporate hospitals, or the private or the public sector jobs, which are non-academic, essentially, when I say non-academic, not in medical colleges or institutes like that, you're looking at either a short-term or a medium-term career. You can think of those in place of a medical college. And if you're thinking of generating or to learn your skills a little further, that's another place you can do a job before you get into practice. Or you could develop a patient base if you're shifting to a new city in that area. And of course, if you, these are just some pointers that you could be doing either in either of the places. And a lot of the corporate hospitals now are having a lot of research and academics also going alongside them. And when do you want to start your own practice? So, there is a dictum, as we said in practice, that the sooner you start, the better if you're intending to do that. So one, of course, it's easy if you're going to be in a smaller city or a smaller town, or if you're going back to your hometown and you essentially intend to be there itself afterwards. So you should start your practice a little sooner. If you've had enough training in residency and your clinical skills and your surgical skills are good, you're confident, again, you should think of doing that. If you have a partner with you, you can get into a group practice earlier. You can divide between the specialities. Of course, you need the financial aid initially to be able to do that. So if the financial assistance is there, that's again another thing that you could consider of doing, getting into a practice early in your career. And that's actually a good thing. So the earlier you start, the better. In my story, of course, I was with the RP Center AIMS. In fact, I did my MBBS there. I went on to do my post-graduation there. I joined as a senior resident. I got into a senior research associate job. I was looking at a faculty post initially, but around that time, I was contemplating different options. Then we were to set up a department at Medanta, a hospital in Gurugram itself, which is a big tertiary care hospital. So that excited me, and that gave me a challenge. So I moved from a public sector setup entirely to a corporate setup, which was exactly the opposite of what that was. But we started research, we started DNB, we started those things. And then along the time, I felt that, it's now time for me to get into my own practice and do all that for myself. And that's when I started my own clinic, Noble Eye Care, and I'm visiting. So essentially, I've had taste of all different forms of what would possibly ophthalmology, would offer in terms of the whether it's a job in the public sector or in the private sector or in my own practice. So based on that, I would say that I still feel probably I could have jumped into practice a year sooner, maybe. But yes, everything has its own learning, and that entire journey did teach me a lot. So the sky's the limit for you guys after residency. So just chart your own route. All right, thank you. So I think the next program.
Yeah, thank you so much, sir. Now we would conclude this session and invite the moderators from the next session, which will start in about 5 minutes.